All right, so we're back from break and back from computer problems or internet problems. So I had talked briefly before I started, probably, and missed most of what I was saying because of the internet going kind of wonky on us. Primary lymphedema is the one that we don't know what causes it. Secondary is caused by something else. And then lymphedema secondary venous insufficiency is also known as tertiary lymphedema. That's lymphedema that looks like it's problems with the venous system, but in reality, it's a problem with the lymph system. And those patients that I've seen with that, the problem there is we often go after the venous problems first. They could, yep, and I'm actually going to talk about that because obesity is a cause of secondary lymphedema. And it can be a cause of venous stasis lymphedema as well, or lymphedema as well. So there's this test that, again, there's a test called a positive stemmer sign where you pinch the second toe that we use to see if it's a venous insufficiency lymphedema. But I just have that on there in case you see something about stemmer sign. It's a test for lymphedema. That's all you have to know about it. And yes, obese people tend to get lymphedema more frequently, mainly because they live an unhealthy lifestyle to start with usually. And so they can end up with chronic lymphedema, usually of the secondary cause. So the secondary cause is going to be they're going to have lymphedema because of obesity. So the obesity is not allowing their lymph system drainage. When you think about it, a lot of some of your nodes are right here kind of in this inguinal region and the lower stomach region. And if that area becomes engorged with adipose, then it's going to be harder for your legs to drain. And so then your legs are going to swell. And it's nothing uncommon for people that are really obese to have swollen legs because their lymph system's just not working as effectively. In the United States, most common cause is damage to the lymph system from breast cancer surgery, especially when followed by radiation. Radiation does not like the lymph system. It attacks it pretty viciously. Worldwide, there is this lymphedema caused by a parasitic roundworm called filariasis, particularly in the subtropic areas of Africa, Asia, and the Western Pacific, and Central and South America. Why did that just go forward on its own? Now I've got ghosts in my house. So that you can get lymphedema. So let me ask you this though, just to test you guys' knowledge here. If the lymphedema is caused by a parasitic roundworm, would that be a primary lymphedema or a secondary lymphedema? Good. It's secondary because it's caused by, right? So risk factors for developing lymphedema could be from axillary surgery and axillary radiation therapy, from breast cancer, lymph node removals, sentinel node biopsies, obesity we talked about. Localized surgery can predispose you to lymphedema, right? Delayed healing wounds or burns, extensive localized trauma, tumors, scarring of the lymphatic ducts by surgery or radiation can all cause lymphedema to come on for you. So they look like pretty bad swollen entire limbs. It's usually one limb over two, but sometimes you can get both limbs. They'll often complain about the joints being heavy and tight. Well, that makes sense. They're swollen. Diminished joint flexibility, aching, discomfort, recurring infections are common. And then eventually the skin will harden and thicken and become kind of like that skin that you saw before with the cellulitis, where it's just basically flaking off. So AJ, I think it asked before, does it feel like, I think it was AJ, I don't remember off the top of my head, does it feel like it's a waterbed? Does it feel firm? Well, it depends, right? If they have pitting edema means when you push on the skin and you pull your thumb off, your thumbprint will stay on the skin. That's what pitting edema is. So normally if I take my arm here and I push down on my arm, there we go, right? If I pull my thumb off, I don't have a thumbprint on my arm. If I have pitting edema and I press down on my arm, my thumbprint will stay on my arm. That's a problem. That means at that point, your edema that's in those areas is really thick and viscous and doesn't want to move. These patients often develop weeping skin. So it's nothing for, because the lymph vessels are so shallow, it's nothing for the skin to start weeping lymph fluid. Often develop deep skin folds, papillomas, and dermatitis is really common for patients with lymphedema. They may develop wounds, ulcerations, pressure injuries, maceration between folds can cause wounds to occur. The ulcers are usually shallow, and the ones that I've seen patients that get ulcers from lymphedema are oozing moist, yellowy fluid. It's lovely. Most common on the arms and legs. Luckily, it's pretty rare that you say lymphedema of the primary body, but you do see it sometimes, especially the head. I've seen it, and that's really creepy. With wound care, we're just going to follow the same patterns. We'll treat the wound. So we have to do I can't pronounce that one. I always mess this one up. Lymphoscintigraphy, where they actually kind of follow lymph vessels and see how the lymph vessels are functioning. They can do an MRI or a bioimpedance spectroscopy or electroimpedance tomography, where they look to see if because remember, lymph has a certain charge. They can use a bioimpedance test to see if the fluid that's causing you to swell is primarily lymph or if it's something else. So usually what we're going to do is multi-layered compression wraps. We're going to use short stretch bandages. What is the difference between a short stretch and a full stretch bandage? Does anyone know? Yeah, elasticity is pretty much it. Okay. So if you think of a ACE bandage, right? A short stretch on an ACE bandage is just going to basically wrap it at the very start of its tension. We're not going to wrap it like some people wrap ACE bandages, where they wrap it and you can literally, if you look at it, you can see through. That's a full stretch. If you can see through that bandage, that's a full stretch bandage. You should never wrap something that tight, right? So we're going to do really kind of a short stretch, usually less than 40 millimeters of mercury bandage. We're going to do that in conjunction with manual lymph drainage or complete decongestive therapy. This can be really useful therapy, and it's really low impact. So if this is something you're interested in, there's always a clientele that has lymphedema. And for the most part, you're not moving these patients around and not doing a lot of heavy lifting with these patients. A lot of the treatments you're going to be doing is in a chair where you're actually draining their leg, and you're going to work the lymph fluid back to the heart and back to the heart. It's really common for you to work this patient and the patient has to pee 2 or 3 times while you're doing it, because all that fluid has to go somewhere and it's going to go out through your urinary system. You can become a lymphedema certified therapist or certified therapist assistant. Those are options as PTAs now. It's really important that the patients clean the area with a pH neutral and unscented soap. Why do you think we want to use unscented soap if they've got swelling like this? We want to use something like ivory or, a Navina that has no scent. Why do you think we want to use unscented soap to clean these swollen areas? Well, let's think about it. Well, could cause reaction. Okay, good. That's one theory, right? Well, let's think. So we got this lady up here in the upper right corner, right? She's definitely got some lymphedema on that leg. If we use something like a Bath and Body Works super scented soap, and then she develops an injury that's maybe infected, is she going to smell that infection? I don't know about you guys, but man, the stuff from Bath and Body Works lasts for like hours and hours and hours on end. So she walks around smelling like menthol and eucalyptus and doesn't smell that she's got an open wound or got an infection. So a lot of times we're gonna do that. The other thing, like Dylan suggested, is some of those scented soaps are not very pH balanced, and they can cause real kinds of problems with the skin. Or monitor skins for infection, apply moisturizer after we do drainage to prevent scars and cracking. Any wound they get, we have to clean thoroughly, and usually you're going to have to provide antibiotics, because most of the times when we have a patient with lymphedema, they're going to end up with an infection. When the patient's working in the kitchen or gardening or anything handling sharp objects, they need to be protecting their skin. Because again, like I said, I had that lady where he just bumped her skin and she wept for days. That happens at home. You may not have a therapist there. And likewise, we're going to tell them to use an electric razor versus a regular razor, because typically electric razors don't cut you. Unless you're like me and somehow I end up being able to cut myself with an electric razor, but that's because I'm stupid. So we're going to tell them to avoid going barefoot, avoid tight clothing and jewelry, especially skinny jeans. I don't know where this freaking, what do you call it, trend came from with these stupid skinny jeans. Well, I look good in them. We actually have had patients with lymphedema that their legs swells while they're in skinny jean, and guess what? Can't get the jean off. There's only one way to get it off at that point. Cut it off. Boot cut cute. But I looked so good in my skinny jeans that I struggled to get into for 2 hours. We're going to avoid applying heat to the affected limb, but we may use heat on our own. So therapists, we may use heat. And this is common for a patient that comes in for decongestive therapy, that we may put a hot pack on them while they're waiting to get their drainage. But we don't want them to do it because we're going to supervise it. You think about it, and I'm sure all of you have seen this, or at least maybe you've had a family member that does it, that uses the hot pack. They've got the plugged in hot pack for the wall. And how long do they use it? For hours on end. They plug it into the wall and they're just like sitting there curled up with the hot pack. I feel good. Well, that could cause problems with the lymph here. If we can keep the affected limb above the heart, we can help drainage. During activity, monitor the affected limb for any change in size. Pay attention to the limb during air travel. This is big for some of you, especially some of you actually had contacted me about this, that, when you fly, your legs cramp up and stuff like that. Well, that's part of not lymphedema, but that's big for these patients. When they fly or travel and they're sitting in a dependent position for a long period of time, that leg will swell. I was on a flight to Philly once where the lady was talking to me. She has primary lymphedema. She was going to see a specialist in Philadelphia. And literally from where we took off I want to say I was in Denver at that point. When we left in Denver to Philadelphia, her leg had gone up almost 3 full inches in swelling. Yep, that's what's happened. So she flies up. Now there's not as much atmospheric pressure around, and so the leg swells outward. Right? And that can happen to even the best of us, right? I get that for some reason. Like when I fly, my feet hurt for like 2 days afterwards. Even if I wear compression socks and I'm up and moving around when I fly, my feet just do not like flying. If possible, avoid medical vaccinations, blood draws, blood pressure in that affected limb, right? For you guys, if you're taking blood pressure, you're not going to take blood pressure on a big, fat, swollen arm. I shouldn't have to tell you that, but don't do that. Right? For patients that get vaccinations, you want to put it in a different arm. If you got a risk for developing lower extremities, avoid crossing your legs, sitting for long periods of time, right? So anything that can affect it and help them avoid swelling, we should really be doing. I think this is the last topic on this lecture, which is amputations. So we're going to get this done and then we're going to cut it out. Amputations, cut it out. Anyway, so this is interesting. They've found artificial limbs dating back to over 2,000 years ago. And actually, I was watching a thing on National Geographic the other day about this. They had found some cave paintings that date to 36,000 years ago that showed people getting amputations. Think about that. So amputation is probably one of the oldest surgical procedures in history, right? Because, when we didn't know how to treat a condition, what's the best way to treat it? Cut it off. The majority of amputations are usually lower limbs, more than upper limbs, and approximately 1.6 million people are living with loss of a limb in the United States. Does anyone know when the largest surge of amputees happened in the United States? You would think that. Civil War. Yeah, Civil War was the one. World War II, we lost a lot of people. There wasn't a lot of amputations, believe it or not, because most of the people in World War I and World War II, they died. But the Civil War, because of the fact that we didn't have the medical advances we had during World War I and World War II, you know, you got a lead bullet into your calf. Well, guess what? Yeah, exactly, right? They stuck a stick in your mouth, they gave you some whiskey and said, bite down, I'm cutting your leg off. And if you ever get a chance, if you guys have ever been back to the East Coast and seen some of the Civil War sites like Gettysburg, there's a field hospital in Gettysburg where they talk about, I want to say, I forget whose house is that in Gettysburg. It's drawn a blank. I should know because I went there 50,000 times. But they have a field hospital set up there. And yes, they show you how they did it. And they have all the tools for what they did for the amputations. And you're like, wow, we have come a long way since then. We now have anesthetics, right? Anesthetics back then was drink a couple shots of whiskey and hope you pass out. And sometimes they use that same whiskey then to disinfect the wound after you cut it off, right? So it's kind of scary, but I just think this is amazing that they found artificial limbs, you know, over 2,000 years ago. To me, this is, I don't know, that just shocks me. I don't know why. You know, and then of course, you know, if you're one of those people that only believes the earth is only 7,000 years old, well, then how did we get 36,000 years ago? Anyway, that's fine. I'm not going to get into that. And we're afraid of COVID. Yeah, I mean, we're afraid of COVID now because, you know, it could kill us. But back then, you know, think about that though, because back in, if we were talking about Civil War time, why would COVID not be as big of a problem? You know, why did the pandemic of the 1918s not kill as many as possibly COVID could? Well, there's one thing, yeah, not too much trouble. There's one thing that directly affects, or actually there's three things that directly affect the spread of COVID. You know what those three things are? Population density, and population density. Those are the three things that affect the spread of COVID. If you look at the areas where COVID's spreading, it's high dense areas of people. We didn't have that back then, right? But at the same time, you know, back then, if we needed to lose a limb, they literally got a hacksaw out of the shed, cut your limb off. I'm pretty confident that in some of the areas that I still live in, or that I lived in back in PA, that's still the way they do amputations. I know I had an uncle that pulled his own teeth, so I'm sure that they still do that. So amputations can be caused by medical conditions and trauma. Medical conditions requiring amputation are often the ones that restrict blood flow. So maybe the patient's got arterial or venous injuries, get diabetes, hypertension, hypocholesterolemia, renal failure. This is interesting. 50 to 70% of all amputations completed in patients who suffer from diabetes. Think about that. Wow. Diabetes leads us to amputations. Accidental trauma happens, crush injuries, burns, frostbite can lead to amputations. Amputations are typically classified either by minor or major, depending upon how much of the body is removed. So somebody getting a below knee amputation would be a minor amputation. Somebody getting a pelvectomy would be a major amputation. So circulatory disorders cause it. Diabetic vasculopathy, sepsis with peripheral necrosis can cause it. Peripheral artery disease, because that can lead to gangrene. Gangrene, gas gangrene smells beautiful. Neoplasms, transfemoral amputations due to a liposarcoma, cancerous bone or soft tissue tumors. Trauma is really common. It's not uncommon to have somebody get an amputation after a car accident, especially if they had, you know, their foot crushed or something like that. That reminds me, let's play the medical thing. What's the most common fracture in a car accident? Does anyone know? Believe it or not, I thought that too. That's a good guess, Renee, but I thought it was wrist, but it's not. It's tib fib. Why do you think that is? Because you're stepping on the brakes, right? I always think that it's the mother-in-law instinct, right? If you ever drove with your mother-in-law and she's constantly stepping on the brakes in the passenger seat, there's no brakes in the passenger seat, Mom. Get used to it. Congenital anomalies, right? Deformation of the leg or limb. Let's say that I have a radius that for whatever reason makes a sharp right turn. I might have to get that amputated. Extra digits. They can do amputations in utero as well for patients that, we know are not going to develop a functional limb. So we've actually gotten so good now with amputations, we can do them as when they're basically babies. Which amazes me. So infections, bone infections, osteomyelitis is probably the one that I've seen most common with patients getting stuff, especially with diabetic foot infections. Gangrene, trench foot, necrosis. Meningococcal meningitis can lead to it if it infects the extremities. Streptococcal infections, vibrovulvanicus, necrotizing fash. We talked about gas gangrene already. Legionella. Does anyone know what Legionella, what the other term for that disease is? Legionnaire's disease. Influenza A, and then animal bites. This is one we don't think about a lot. What animal do you think causes the most amputations? Rabies. Okay, good. Believe it or not, it's cats. This is one where the cats are evil. Well, why is that? Well, snakes could, but we just don't have a lot of them. Why do you think cats cause amputations? Yeah, they have a specific type of bacteria in their saliva that they use naturally that doesn't agree with our body. Because cats are the best. Dogs just lick their butts and then lick your face. But animal bites can cause it. Sepsis, the bubonic plague, right? All of you, if any of you haven't watched Monty Python and the Quest for the Holy Grail, it's a great documentary on the bubonic plague. AJ's laughing. Good, I appreciate it. I made AJ laugh. My job is done. So key thing here, I wanted to beat this home to you guys. It is not a stump. It is a residual limb. Cat paws are cute. They have little toe beans. So do not come up to your patient and say, okay, we got to take care of that stump. Why do we not call it a stump anymore? It stumps me. Well, stumps are considered negative connotation. Yeah, emotions, right? It reminds them that they don't have a limb. Lucky cat stump. So what we tell them is you have a residual limb. So you have some limb left, right? But it's now residual. It's whatever's left. It's to kind of get a little bit of mental things going on. Of the lower extremity, we can do a partial foot amputation, right? Amputation of the lower distal to the ankle. You can do an ankle disarticulation. Transtibial amputation. A transtibial amputation is also a below knee amputation. Transtibial across the tibia. I'm going to tell you a funny joke about this here because this was Mr. McKeever going through PTA school once. You have to understand, I came from IT world, and I came from Pennsylvania where we have Lebanon bologna. And Lebanon bologna is probably the best bologna there is. But that's beside the point. I won't even argue that. But my teacher kept talking about a bologna amputation. And I'm like, why are we amputating bologna? I don't get it. Is it because it looks like bologna? I don't get it. And she was really saying below knee amputation. And I heard bologna. And so I'm like, why do we call it a bologna amputation? I'm not joking. I asked her, I'm like, do we call it a bologna amputation because it looks like a piece of bologna? And she like stared at me for, yeah, bologna amputation. I was like, and then she's like, oh, my summer child, let us talk. Below knee amputation. I've never been so embarrassed in my life, but to this day, it is still one of the funny, like every time I see Renee now, she's like, hey, how's that bologna amputations going? Shut up, Renee, shut up. So transtibial is a below knee amputation. You'll never forget that now. Knee disarticulation occurs at the knee joint, right? So we're going to take out the tib fib. You can also do a transfemoral amputation. If a transtibial Yeah, it is spelled weird, right? Exactly. See, in Pennsylvania, we don't have this. We don't have Bologna. We have this. It makes more sense, exactly. And we have bologna. So if a trans tib is a below knee amputation, what do you think a transfemoral is? Across the femur. Above knee. Good, right? And there's no funny story about that. I understood that one. I was just being dumb. Hip disarticulation, removal of the hip. There is things called transpelvic disarticulation where they remove the whole limb plus part of the pelvis, also known as hemipelvectomy or hindquarter amputation. I got some fun amputations here to talk or to think through. In the upper extremity, we can do a partial hand, we can do a wrist, we can do a transradial amputation, also known as a below elbow amputation. In elbow disarticulation, a transhumeral or above elbow amputation, do a shoulder disarticulation. And then we have the four-quarter amputation. Does anyone know what a four-quarter amputation is? Has anyone seen anybody with that before? It's not four things. That always confused me. Yeah, so they take out, when they do a four-quarter amputation, they take out the clavicle, they take out the scapula, and they take out the arm. So you only have that trunk left on that side. Good guess. That was actually really smart. You're SMRT. I mean, SMART. So other amputations, you can amputate the ear. You can amputate the nose, called a rhinotomy. If that's called a, you'll take it, okay. If that's called a rhinotomy, then what is rhinorrhea? Use your medical terminology here. What do you think rhinorrhea is? Runny nose. Yes. Rhinorrhea means runny nose. Because diarrhea means something else being runny, right? So rhinorrhea is runny nose. Tongue amputation, a glossectomy, eye amputation. I don't know why the eye is an enucleation. I tried to find out why, but it doesn't seem like there's any logical reason why it's not like a optectomy or something like that. Teeth, right? Sometimes we are forced to have teeth amputations. Why might we have to pull a tooth out? Cavity, right? The tooth is gone. I never show you guys. That's one of the reasons why I don't smile, but I'm missing most of the teeth in the bottom part of my jaw from that because I got a really bad infection on my jaw. Can I have an amputation of the breast, a mastectomy? Testicles is a castration. You can have an amputation of the penis, being the penectomy, the foreskin, which is circumcision, and the clitoris, which is a clitoridectomy. Now, most of those down from breast down are also really common in genital mutilation, right? And that can be a common religious thing in certain religions where they will mutilate people's genitals. Does anyone know why they mutilate genitals? Primarily, it's usually women that get their genitals mutilated. It's a really scary thought process. Has anyone ever heard of genital mutilation? Anyone still awake? Yeah, a lot of times, well, it's common in the northern African tribes and stuff like that. A lot of genital mutilation occurs because they want to take pleasure away from the woman. Because a woman shouldn't be having sex to have pleasure. It should be just having sex to reproduce. Yeah, it tends. It's not only Hispanics. There's other religions as well that don't do circumcision. And we could talk about that all day long as to why we should or why we should not. But I'm not going to get into that. That's totally different class than wound care. But yeah, I mean, it's not uncommon. And when I was back on the East Coast, I saw more genital mutilation than I've seen out here. And I don't understand that. I have a hard time grasping that. And I'm pretty confident this would be why I could never be a cop, because I'd lose my badge so quick. So when we do the medical assessment for somebody who's amputation, it needs to be made by a specialist in that area, right? This is not a physical therapy decision. We're not going to talk to a patient and say, hey, you've got a really bad infection of foot. We should probably consider amputating it. The surgeons are going to make that decision. And the surgeon will usually make the best decision for the patient to prevent further spread of the infection. So a lot of times they're going to make the decision based on if or when that there's, a problem. If that infection is likely to spread, they may take more of the limb, right? I told you guys about the guy that had gastric gangrene of the foot and they took a Terence tib. Well, the main idea was that infection probably was all the way up to the tibia, so they wanted to try to prevent him from getting further loss later. The doc's going to have to go in and bevel the bone after the surgery. So let's say I'm getting a bologna amputation. They're going to have to go in and cut, first of all, cut the bone. Hopefully they anesthetize me and I'm out. Then they've got to bevel the bone. Beveling the bone is going to set us up for using prosthetics later. They're going to have to do a nerve resection, meaning they're going to have to cut on the nerve so that the patient doesn't have an oversensitive nerve area. So a lot of times those distal ends of those residual limbs have very little sensation. Then they're going to put a flap on where they take the skin and roll it back to cover the actual wound itself. Then we have to find somewhere to attach soft tissue, right? Because think about it. Let's say I'm having a bologna amputation. I still have to make sure that my quad tendon's attached. But not only that, but if I go back down there, I've got all those other muscles in my lower leg. I've got my gastrocs, I've got my tibialis anterior, tibialis posterior. What do I do with those tissues? I may have to reattach them to other places or cut them out entirely. What type of closure are they using? Are they using staples? Are they using laser? Are they using stitches? And then the bone length will help us determine the prosthetic length, right? So you do need to know the difference between a myodesis and a myoplasty. A myodesis is where during an amputation, a doctor reattaches a muscle to another bone. A myoplasty, I always think of as plastic surgery, so they're attaching a muscle to muscle. Why you have to know this is because it's part of amputee care, right? And we have to understand if they did a myodesis where they reattach the muscles to bone, or if the muscles are reattached to the muscles, therefore providing a little bit more cushion. So physical therapy may be used in the pre-amputation period. So before the patient gets the amputation, we usually are going to see them. It's mainly to determine their functional status. If I've got a patient who doesn't walk much before amputation, and they come see me and I assess them and they're just not moving around that much, there's a good chance they're not going to walk much after amputation, right? After amputation, the physical therapy is vital to provide patients with as close to normal function and return to life as possible. Now, we're not going to be able to replace that limb, but we can give them prosthetics. The first and foremost job that we have in physical therapy in wound care with residual limbs is to shape the limb, right? If we do not do limb shaping, the prosthetic will not fit, it will not articulate properly, and then the patient will be likely unable to get a prosthetic, and you'll have a prosthetist yelling at you. I had a funny story about that before too. I had one of the cohorts before was like, well, why are prostitutes getting involved in this? No, I said prosthetist. Prosthetist. There's a big difference. One provides fake limbs, the other provides other stuff. And if you don't know that, I can't help you. Okay, I made Erica laugh at least. So when they first come out, we're going to put a rigid dressing on that residual limb. That rigid dressing is going to look a lot like a cast, right? The reason we're going to put that rigid dressing on is it's going to form that skin to exactly the way we would like it. Then we're going to take that rigid dressing off and we're going to start using shrinkers. And shrinkers are exactly like they sound. They are really, really high compression sock garments that help shape the limb by squishing it. And then eventually we'll move them to prosthetic socks, which are the socks they put on to guard the limb when they put a prosthetic on. We'll discuss more about the prosthetics themselves in the P&O lecture, so get excited for that, for those that might be interested in prosthetics and orthotics. But just understand that we will go from a patient from a rigid to a shrinker to a prosthetic stock in order to get that limb shaped so they can fit in their prosthetic. Primary objective are to keep flexion, internal rotation, and adduction contractions to a minimum. So no matter what limb I get, I want to make sure I try to keep them from getting stuck in a flexion status. Let's think maybe I have a transfemoral or an above knee amputation. If I get a flexion contraction where my hip is stuck into flexion, am I going to be able to use a prosthetic effectively? No, right? So we have to stretch them quite heavily. A lot of times and I try to recommend it to most of my amputees, is if they can sleep on their belly, sleep on your belly. Because sleeping on the back, we can end up going into that flexion, where if you sleep on the belly, it kind of pushes that limb back into extension. So we're going to work on stretching, therapeutic exercises, orthotics and prosthetics training. If they're not a candidate for orthotics or prosthetics, then we may have to look at a wheelchair for them, right? And then also dealing with assistive device training and dressing changes. We have to teach them how to take care of that residual limb. So that covered most of the wounds that we're going to deal with. There are other wound types out there. Abrasions, right, which are nothing more than like your burns, your mechanical burns, skin tears, surgical wounds, right? Compartment syndrome. Does anyone know what compartment syndrome is? Did anyone encounter anyone with compartment syndrome while they're in their clinics? I'm really surprised. Did any of you go to the VA? I can't remember if we had somebody going to the VA this trip or not. I think we have somebody going next trip or this coming clinical. Yeah, okay. So compartment syndrome is where, for whatever reason, one compartment of a limb starts getting abnormal swelling and pain. So maybe my compartment is my forearm here. It starts swelling. Well, my skin only has so much room it can swell before it starts pressing inward. Once it starts pressing inward, it's going to start destroying the tissue underneath. So that's where we talk about those fasciotomies, where they'll come in and flay open my skin to allow the pressure to kind of weep out. Not very fun for patients. Traumatic wounds. Bites are really common. You'd be amazed at how many bites the doctors actually see in the emergency room. I worked the medical tent at, what's that festival up at the racetrack every year? Thank you, EDC, there it is. I worked the medical tent at EDC the one year, and you'll be amazed at how many bites I had to clean and dress. I don't understand what the fascination was at that with biting, but there's multiple people came in with bites in places that you would not normally see bites. Yes, from humans. It was also just interesting dealing with that whole crowd to begin with. Lockjaw from all the jugs. Exactly. I only did that like 2 years, and then I decided I didn't want to do it anymore because traffic getting back from there is so bad. It's ridiculously bad. Radiation can cause problems. Where might somebody encounter radiation problems? What type of patients might you encounter that might have some radiation burns and stuff like that? Well, obviously, if they're getting cancer treatment, they might encounter it. Thumbs from phones. That's probably coming down the line. I'd be curious about that. Patients, even radiologists and radiographers, I wouldn't doubt eventually we're going to find more things. They've already found, they did a study, Cambridge did a study that they can now actually actively tell what pocket you carry your phone in when you get older, because that bone, that hip has greater wear and tear from the cellular signals. So partially she's right. They did a study where they looked at people and were able to prove that like the person carries their phone in their right pocket because that hip has more breakdown than the other hip. It's actually pretty interesting. People that work in radiation, specifically nuclear plants, I had that more than you guys will have that back in Pennsylvania, because where I lived, we had 1, 2, 3, 4 nuclear plants within about 150-mile radius. We don't have as many nuclear plants out here, and we haven't built a new nuclear plant since, I think, 1978. So I don't know why we discussed that partially in physics too, but where's our closest nuclear plant? To Las Vegas. Anyone know? I mentioned it briefly. It's Palo Verde in Phoenix. There's a nuclear plant at Palo Verde. It's run by University of Arizona. All right, let's look at some quick knowledge check times here, because this is to tie it all together. So a patient enters your clinic with leg pain of unknown etiology, but no wound. Supervising PT wants you to do a quick test to rule out arterial and/or venous insufficiency. He asks the person to lay supine and elevate the limb. Would arterial or venous insufficiency cause pain? By elevation. So I've got an A, I've got an A, I've got one venous vote. So remember, with venous, what does the patient's limb feel like? Does it feel painful, or what's it normally feel like? Dull and heavy. Yeah, right. So with arterial wounds, when you elevate the limb, it's going to start hurting because you're increasing the arterial load and it's not able to get the blood flow out to it. So arterial, that's okay. That's why we're doing this. Arterial insufficiency is the right answer. All right. 50-year-old woman presents with an edematous lower leg, medial leg wound that is moderately draining and mildly painful. So we have it on the medial aspect of the leg and it's got drainage. What type of a wound do we have? Okay, so I got venous, I got venous, I got venous, and it would be venous. Good. All right, which of the following is most likely to access and accurately measure change in gas perfusion of the skin? We have venogram, ankle brachial index, transcutaneous oxygen tension, and capillary refill. Okay, so I've got a couple capillary refill. I got one capillary refill, I got one B. The ankle brachial index is to help us determine what? If they've got a problem with their flow itself, if there's a problem with the actual vessels. So remember, I said this, the capillary refill test does a similar thing. It helps us understand if oxygen is getting out there, but it's not as accurate as the TOM or the TOT, depending upon what you're doing. Transcutaneous oxygen measurement or transoxygen tension, the TOM or the TOT. So C is the right answer here. 71-year-old lady presents with compression bandages. She has edematous leg that currently has no open wounds. She has arthritis and lives alone, but does have a caregiver come 2 times per week. What is the best compression option for this patient, assuming the ABI values are normal? So this one gets a little bit tricky. Okay, so I've got stockings. Got D, good, I got stockings. Right, so why would we do stockings with this lady rather than, first of all, let's rule out B. Why are we not doing B? Well, ace bandage at 50% stretch is too much tension. Right, that's gonna be way too much pressure. That's gonna be closer to 100 millimeters of mercury, and we don't want that with somebody with an edematous leg. The Una boot's an option. And I don't know how many of you watched that video about the Una boot. The Una boot would be an option, but we're typically not going to do that on a patient that can care for themselves. And she's got a caregiver coming, so putting stockings on and taking stockings off, it's a pretty good option. Elevation of the legs is not going to do anything, right? Elevation of the legs, I mean, it'll help, but that's, if we're looking for compression, the 40 millimeter stockings are the best option. 87-year-old patient presents with dry ischemic necrosis on a distal toe following a failed attempt at revascularization. What's the best treatment option here? Okay, so I got an A, got an amputation. Okay, I got A, got an A, got an A. Why do you think that's the right answer? Because that is the right answer. What's the key thing that tells you it's probably going to be necrosis? Good. And then the failed revascularization. Yeah, right. That means the doc tried to fix the blood vessels, but the blood vessels couldn't be fixed. At that point, we're going, there's not much we can do for it. We're not going to get blood flow back to that toe. The best option at that point is cut it off. Now, we're going to go back to the back, get an axe, and just come out. No, send them to a surgeon to get it cut off. Which of the following would be most likely the cause of a wound 3 centimeters proximal to the medial malleolus? What do you think? Got venous insufficiency, got venous. Venous is true. That's probably the best. Now, could we also argue animal bite? Could we maybe argue for that? Could, right? But we don't have enough information for that to be the right answer. Like now, if it said that, 72-year-old Millie lives alone with her 40 cats and has no known issues of vascularitis or anything like that, what will be the most likely cause of a 3 centimeter wound to above the medial or malleolus? Then we probably would be thinking animal bite. Right. The most likely in this point is the important thing. You're exactly right. That's why I put this in here, because that's the exact thought process I want you guys to have. Most likely means what is the best option? Because if we do animal bite, we have to assume that she's around animals, and maybe she just doesn't like animals. Which of the following types of ulcers is characterized by a small round lesion, usually on the toes or the distal foot, and is exacerbated with ambulation? I got A, got A. It looks like we're universal here. A is the one, right? And what is the most important thing that we can do then for those ulcers on the bottom of their foot? What was that thing I said was the most important thing we should do? Foot check's good, right? They'll help keep them from happening, and then offload it, right? Get the weight off that injury. So put a dressing on it that can help with it. Patient has just completed a venous filling test, and it was noted the time for the superficial veins in her foot to refill was 20 seconds. What is likely the problem? This one should be a universal quick answer for everyone. I got a B, I got a B. B is the answer, right? It says we're testing the veins. If we're testing the veins, then it's venous insufficiency. Right? Just don't get tricked up with that, because here's the deal. You could get on your boards and get this question, and you're looking at it going, but man, arterial insufficiency looks good. Now you're never going to only have 2 answers. Right? This is the one that makes you feel so dumb. Exactly. Especially if you got it wrong, right? This would be the one that you'd get wrong. You'd look at it afterwards and go, why did I pick arterial? This one has all the clues you need in it, right? It tells you that it's a venous fill test. It's superficial veins, and it's abnormal. It's venous. And that's the problem you have to be aware of. Sometimes those easy questions are just easy questions. It's just what it is. Sometimes they're, not all of your questions are going to be really hardcore questions. Some of them are going to be simple, like, what is the origin of the biceps brachii? And that's where you sit there freaking out going, man, this question is way too easy. And you start double thinking it, and you're like, no, this is just one of those level 1 questions. I answer it and move on. Now, a question like this on your boards is not going to be worth a lot of points. But man, exactly like Emily said, you're going to look at this and go, this just seems way too easy, and you're going to overthink it. Don't overthink it. It's a venous fill test, superficial veins, venous insufficiency. 50-year-old patient with an unremarkable medical history presents to the clinic with round wound with well-defined edges on her lower leg. She reports that it is uncomfortable to sit in her favorite chair with her legs elevated. What type of wound is this? Okay, so I got some A's. Got a D. Okay, could be, right? So let's think through this. So the answer is going to be arterial, right? What are some clues that tell us arterial? What are some clues that lead us into arterial here? Because it could, I mean, that's the thing, is that the shape. Yeah, right. This is going to be one where the pressure ulcer is there, but we don't have enough information to assume it's a pressure ulcer. And also, we shouldn't be seeing pressure ulcers anyway because we're calling them pressure injuries now. The shape of it's the main thing. It's well-defined round edges, right? That we know is typically arterial. It can also be pressure injury. The main thing also, she says, reports it's uncomfortable for her to sit in her favorite chair with her legs elevated. Anytime we start talking about elevating something, it's typically going to be arterial unless we're talking about lymphedema. Right? In this case, she's got a wound. It's uncomfortable for her to sit with her legs up. It's an arterial ulcer. Now, what if I change this a little bit? And now the round wound is on her ischial tuberosity. Now it's a pressure injury for sure. Yeah. Right? Because now we're talking about a pressure injury in an area of high pressure. But because it just says on the lower leg, we don't, and that's the thing. With this one, it doesn't tell us if it's medial or lateral. I'm going to assume this is lateral, right? But I'm looking at it going, well, it doesn't matter because I know I've got a round wound, I've got round, clear defined edges, and she doesn't like having her legs up. It's arterial. Now it says on the sacrum. Again, we're back to pressure injury. Because remember that those diabetic or the venous ulcers themselves are irregular in shape, and the diabetics are on the typically plantar surface of the foot. All right, so it is what time currently? It is currently 10:23. So I've got you for about another hour. Do you want to take a break now? How are people feeling? How's Emily feel? Does she need a break? Good. Does anyone else need a break? Because I can break, or I can let you out a little bit early before Dr. O'Neill's class. So I've got about, okay, let you out a little early. Okay. Let me bring up, let's see, let me see here. Give me 1 second. I'm gonna bring up my YouTube studio here. So sad, you guys aren't subscribing to me. I'm very sad that you guys don't like me. All right, this is not going to be comfortable for me because I'm going to get to watch myself do a lecture. I have a YouTube account. Well, just sign up with one with your email address. Anyway, let me share screen here. Maximize this. This is going to be really uncomfortable because I'm going to be watching myself. So this could be really uncomfortable for Mr. McKeever here. All right. Hi, Mr. McKeever. Hi, Mr. McKeever. How are you doing? I'm doing great. So there's this video up, and then there's also a video on dressing the wounds. I'd like you to watch dressing the wounds video on your own, but this we're going to talk about supplies. This was done in that place. I don't know if you guys remember this place. Have you ever seen this place before? Vaguely remember it? So I'm going to walk, this is going to walk you through, and I'll add some commentary as we go through, but because I haven't seen how bad this is, so this could be bad for me. On Wednesday, unfortunately. Okay, so I recorded this for the last cohort, so please, I'm sorry that it's maybe not directed at you guys directly, but the wound care supplies is important. I recorded this on my own, so. The previous lecture had gotten. All right. So when we talked about the wound care dressings, a couple of things we talked about was mainly A, there being a primary dressing, and B, there being a secondary dressing. The primary dressing being. Hold on. What's the difference between a primary and a secondary dressing? See if we at least got that. What's the primary dressing do? Do I have anyone? Primary packs the wound. Good, right? Secondary does what? Covers and protects. Good. Yep, there we go. Good. The one dressing that is actually in the wound itself that protects the wound and promotes the healing inside the wound bed itself. The secondary dressing being the one that provides the cover and the protection for the over wound area and the peri-wound area. So when we're dealing with that, our primary dressing that we deal with on a most common basis, obviously, is just standard gauze. Gauze is going to be labeled by its size. So in this case, this is a 4x4 gauze pad. Most of the gauze does come in these nice containers, which makes it easy because then when we need to dampen the gauze, we can actually just use saline, standard saline, and put it right in here and keeps things from getting all messy. There's your standard gauze is your traditional type of gauze that you're going to deal with. This is going to be packed in most wounds. This is going to be the filler for most wounds. On top of the standard gauze, obviously, there's impregnated gauze, right? So impregnated gauze, most common are either Zero-Form or Adaptac, which is Adaptac here. Impregnated gauze is usually impregnated with petroleum jelly. So that petroleum jelly, then, the job of that is to keep this from sticking to any surface that would normally stick to. So just before I continue, Mr. McKeever, give me a second. What kind of structure maybe in a wound might you want to put a piece of impregnated gauze on that stuff might stick to? So if I pick impregnated gauze, which has the petroleum jelly in it to kind of keep things from sticking, let's say you have an open wound on a patient. What type of stuff in the burns could stick to? Good, right? And also the other B, bone. Because if you have bone exposed in a wound, the dressings love to stick to it. So then you're picking off the dressing off the burn or the bone. So impregnated gauze, a lot of times if we have exposed bone, tendon, ligament, organ, something like that, we're going to lay the impregnated gauze over that so the stuff doesn't stick to it. Example, that would be bone or any type of tendon. Hey, I'm smart. If you have exposed bone, exposed tendon, your normal traditional gauze, right? Your normal traditional gauze with its nice fibers and stuff like that tends to stick down to those type of materials. So you need something that will keep it from sticking. So your traditional impregnated gauze is usually what we're going to use. Again, Zero-Form, Adaptac are your kind of most common forms, but there are all kinds of them out there. Curad makes one. There's all kinds of them out there. In addition to those, obviously you have every other type of dressing you possibly have, right? So here we have a non-adherent pad. A lot of times these pads you're going to see across the front of a knee surgery. And again, this is just non-adherent because the knee's going to have staples in it, and they don't want the gauze sticking to the staples. This will keep the gauze from sticking to the staples. This is just your standard foam pad, another non-adherent pad, as you can see. Usually your non-adherent pads have this nice shiny texture to it. And then, of course, your traditional ABD pad, you're going to see a lot in a heavy draining wound. This is a gauze pad surrounded by a protection, but inside it's very, very thick cotton, and that'll absorb most anything in a heavy draining wound. But there are other better options than this nowadays. But this was the traditional usage when we had a heavy draining wound, was just an ABD pad. It's still the cheapest type gauze. And then, of course, that's one of the things I want to bring up here, because I didn't bring it up in this video, is a lot of your wound care dressings are going to be chosen on what is cheapest, because we don't get a lot of reimbursement for wound care. So I know it sounds kind of callous, but a lot of it's going to be based on what's cheap. Of course, there's gauze stripping, right? So here we have two different types of gauze stripping. The gauze stripping is exactly like it sounds. It's just gauze. So why might we use that gauze stripping? Where do you think we're going to pack that in? Tunnels, good, yeah, right? It's gonna be a lot easier to pack that in a tunnel than a 4x4 gauze pad. And also it's gonna be a lot easier to get it out, right? Literally I can leave a tail and just pull that right out of the tunnel. And strips, what can we use that for? We can use that for packing in, undermining, and tunneling. It comes in your traditional normal gauze, and then also iodinized gauze for wounds that are infected and things like that. So that's kind of your general primary dressing stuff. Not getting into the specialty dressings yet, but that's just your general primary dressings. Getting into your secondary dressings, the most common things you're going to encounter on the floor when you're working with patients is just your standard, everyday, ordinary border gauze, right? And when we think secondary dressings, most of the times what we can think of is just a Band-Aid, right? This looks like an extra large Band-Aid. It's got a little bit of a gauze pad attached to it, along with adhesive binding so it can stick to the peri-wound area. There are all kinds of them out there. This one's a heel dressing, obviously. There are sacral dressings. There are long, thin dressings that can go down your wounds, such as total knee replacements and things like that. There are smaller ones. There are larger ones. It just depends upon what your needs are. And these here particularly, these gray ones, are silver impregnated. So the point of a lot of silver impregnation in a lot of the materials that we use in wound care is silver is shown to have great antimicrobial and antibacterial effects. It's actually bactericidal. So it can help kill off any of those germs to get in there if your wound is infected. This is another one that's got a little bit of that silver impregnation in it. And then here's some other ones. These are biotanes. And biotanes, when we talk about the wounds that may be over really heavy bony prominences, a lot of times we're looking more into these. And these are kind of your secondary foam border gauzes. This gauze has a nice thick layer to it, right? It'll allow it to adhere to the wound area, this peri-wound area, because of the tape. But say you have an injury on something like the lateral malleolus or medial malleolus, and the patient is planning on wearing shoes. Well, the shoe might dig in every time they plant down or they're walking, so you might want something with a thicker foam area in order to provide them with a little cushioning, right? This one's by Coloplast. Here's another biotane wound dressing, right? And this just provides a nice, thick, protective layer, right? Or maybe you have something on the sacrum where you need a little extra cushioning back there because they've got sacral breakdown, and you're worried about any type of further breakdown. You can use foam dressing in order to help with that. Other than that, then we go into our kind of other dressings that you're commonly going to see, such as your hydrocolids, right? So your hydrocolids, as you can see here, are a little bit thicker than your traditional gauze dressing, right? And what they are is they are a impenetrable barrier from things such as, and here's, this one's kind of really thick, you can see it. They're an impenetrable barrier, so if your patient maybe is incontinent or something to that effect, you could use a hydrocolid barrier over top of your wound, and that will keep any bacteria or anything else out of that area, specifically. And the other thing I know I don't mention in this because this is something I realized after I had done this video. Hydrocolids have two different sides. They have the impenetrable barrier on the outside, and then they have a gel barrier on the inside. And the gel barrier, you can think of a lot like baby diapers. That gel area will swell to absorb fluid. So they often swell to 2 or 3 times their size, so they absorb on the inside and keep stuff on from the outside. Fluids and breakdown and fecal coliform and all that fun stuff. The downside to these is they also don't allow any breathing. So if you put one of these on, it's going to block everything out, including the oxygenation of the wound. So be aware of that. But these are great for protecting wounds, especially in areas that are going to get very wet, very sweaty, or have any type of urine or fecal input on it as well. And then you have your traditional. These are just nothing more than your traditional, commonly heard as Tegaderm or film dressings, right? These. So what type of a dressing, what type of wound will we put a film dressing on? Remember what the number one one I said we usually put it on is? So the films we can see through. Yeah, that which stage pressure injury? Stage 1's good. Dressings are mostly perfectly clear, and those dressings allow you to lay it over a wound or even a surgical site so that you can actually see what's under, especially when you need to see under types of the underside of the wound, so you can look into the wound while you're maybe keeping an eye on it, such as if you have a stage 1 pressure injury. This can go over that stage 1 pressure injury, and then what that's going to do is that's going to create a nice barrier, right? So if we take this off and we apply it, right? So we're going to apply a little bit of it, and we apply that down, right? That's going to create a nice area where it's going to be friction free. Right? So that means that if this was on a sacral area or an ischial tuberosity or calcaneus or anything like that, that'll provide an area where now that area has a nice smooth area rather than have an area of friction, right? And it'll protect that skin, keep it from breaking down even further. One thing I also don't cover about those wounds, because I cover it in another video I do about ultrasound. If we're doing ultrasound on a wound bed, because we do ultrasound on wound beds, but we don't want to stick the ultrasound head down into the wound bed and get goop all over the wound head, the ultrasound head. We can put one of those clear dressings down, put the ultrasound gel on top of the dressing, and the sound will still penetrate them and keep most of the wound gunk off of the ultrasound head. You also have your clear film dressings, which I've talked about. And then, of course, you have your masticols, or mastisols. These are nothing more than liquid bandage, right? These can be used two ways. For small, minor cuts and abrasions, this can be used almost as a primary dressing itself. Oftentimes, you'll hear this as liquid bandage. Or the other way this can be used is if you have a dressing such as a primary and a secondary pad that's not sticking down, you can use this mastisol around the edges of the wound, and that'll allow these edges to be more adherent, right? So maybe your patient's skin is just, super oily or something to that effect. This stuff can help that other bandage stick a little bit better. So one of the first things we have to determine when we open up a wound, we're going to open up a wound in the second video, is that wound draining heavily? Is it draining enough? Or is it draining too little? Right? Meaning, does it have a lot of, what's the fluid content of that wound? If it's too heavily draining, that's a problem as well. We want a nice, warm, moist wound environment that is enclosed, but we don't want it too moist, and we don't want it too little moist, right? We want it right in that nice middle area, just like Goldilocks and the Three Bears, right? It's got to be just right. If we don't have that just right area, it can cause problems. So what happens if a wound has too moist of an area? Well, if it's too moist, we're going to turn to something that's going to absorb it. We can pack it with extra gauze. It's absolutely. We used to do wet to dry dressings all the time where we would put dry gauze in there, let it suck up all that fluid, and then just pull it off and pull out all that gunk that way. We found that that dries out the wound a little more. It's probably not the best idea. So now when we do put gauze in wounds, usually it's going to be dampened with saline or something of that like. What we can do in addition to that is we can use things like alginates if it's too moist, right? So alginates, these are some examples of alginates, right? These are a common sort of really finely woven material, right? And so a lot of them come from algae or some sort of a bioproduct, right? These absorb 20 times their weight in size. So we can cut a small piece of this off, right, such as using something small like this or this, and that can provide most of what we need for a heavily draining wound. These absorb so much fluid and they protect it. We can cut them to any size and it'll fit. We don't want to put too much in there because if we put too much alginate in, obviously it's going to dry out the wound bed. So we have to, again, be very careful about how much we put in. But this is going to suck up all that exudate, all that serous fluid, any type of slough or anything that's going to be in there. It's going to get sucked right in towards it. I prefer the alginate to come in stripping like this, just because it's a little easier to cut and a little easier to manage. You can get alginate like this. Alginate comes in rolls like this. So there's any number of ways alginate comes. In addition, just like any other dressing that's out there nowadays, they can come in silver. And just be aware that anytime we start talking and adding silver to any dressing, it's going to increase the cost. So you have to be aware of that, right? We don't want to use silver unless we're told to by the PT or told to by the doctor. We have to have an order for this type of stuff. If we don't have it as PTAs, we can't just go, oh, well, I'm going to use the silver dressing today. No, we need to have the order to do that. If the wound is excessively drainage, we don't necessarily have to go get the PT in order to use the traditional alginate. But in order to use the silver alginate, we would need to get PT approval to do it. And then here's another, this is just Max Absorb AG again, just another silver impregnated dressing. You can see it's just a little bit grayer than your traditional white alginate. All right, so these are alginates. We also have our collagen dressings, right? So our collagen dressings are for moderate to heavy drainage, almost very similar to your alginates, right? This is a Pure Call Plus dressing here. It's collagen dressing. It will turn itself into a very, very soft, gooey gel after it absorbs the exudate, allowing for easier removal. It often will be used in static wounds or wounds that are stuck in the healing process to kind of facilitate that actual progress towards healing. Again, these absorb a ton of fluid as well, but they turn into this jelly kind of fluid that allows everything to be kind of wiped out when we're cleaning the wound. We can also use something like Iodosorb, right? Iodosorb is a gel, it's a catexamer gel. It helps pull some of that excess fluid up and out. And the nice thing about this one is this one has iodine in it. When it goes in one color, and as the iodine wears out, it changes color. And as it changes color, that tells you when it's definitely time to get the dressings changed, right? So this will go in and help kill bacteria, help keep a nice, healthy wound area, right? Can even help to soften some of those areas that might need some debridement and stuff like that. But this works well as well. Optifoams, right? Optifoams are just more cushioning. Again, I don't seem to have one sitting here. Optifoams are a thick cushioning material that can be put inside the wound, again, to provide a little bit of extra cushioning. It can be used for moderate to heavy drainage as well, but preferably, obviously, we go to the collagens or the alginates at this point when we need something that's really heavily draining. We have these Hydrophera Blues as well, so Hydrophera Blues. The Hydrophera Blue is a bacteriostatic dressing, right? It pulls the bacteria and any type of infection into it. It's a super powerful antibacterial wound dressing. It uses PVA and polyurethane foam in combination with two naturally occurring organic pigments, so this blue and this violet. And what it'll do is it will suck all of that into and it'll swell up. And then what that'll do is that tells you that it's time to remove. They say that this can be a 2 to 3 day dress time period, but again, most wound care places are going to change dressings every 2 days. But these come in any size, and these can be cut to sizing, right? So if you only need half of this, only use half of it. Don't try to fit something into a wound that's not going to fit. The ideal goal is if we have a round wound, we want to take this and fit it to the round wound. If we have a square wound, we'll use the square. If we have oblong, we may have to use something bigger. But you're going to cut it to fit the exact size of the wound, and it's going to help draw up that infection. So say you opened the wound up, and the wound had a foul, real sour odor to it. We knew that it's infected. You can use this dressing to help drain some of that bacteria and infection out so that we can move on to more traditional style dressings like gauze and maybe even alginates, right? Acticoat. So Acticoat's a relatively, advanced form of wound dressing, right? This is the Acticoat Flex. This actually allows it to lay over body area so it fits nice and even. You're gonna see this a lot in burn patients. This is it's a proprietary silver dressing. They say that this has 3 to 4 days wear time, according to the manufacturer. But again, most wound care companies or wound care areas aren't gonna wait 3 to 4 days to change a dressing. But they come in all type styles. This one's a little bit thicker. It helps absorb some drainage as well. It has extremely low adhesive capability, so it's not gonna stick to your wounds. And also, they say that this actually starts doing bactericidal type work within 30 minutes. So as soon as you put this on, within 30 minutes, it's already starting to kill some of the bacteria in that wound bed. So that's really effective at taking care of that. And again, you have just the standard size. And this can be cut to fit wounds as well. So if we only need half of this, we could cut this to fit the wound area, right? So we want to make sure that these type of stuff, anytime we get into this Acticoat, we get into the Puricol stuff, we're talking a little bit more money for the patient. So you have to be aware of what your clinic and what your hospital is going to use for the wound care itself. Those Acticoat dressings that I'm showing there are about the small one that I showed, just that little kind of flimsy paperwork or papery type dressing is about $75 for that dressing alone. So the wound care dressings can get really expensive really quick. Right? I really like this on burn patients just because it allows me to literally lay that dressing right over the wound area itself, and it conforms to it. And then when I put secondary dressing on, it fits right over the wound. So if I had hand burn, I could literally fit this right over the top of the hand and then dress the hand, and it's not going to cause that much of a problem. So we talked about what happens if the wound is too moist. Well, what happens if it's not moist enough? Then we need to donate moisture to it, right? So obviously we can donate moisture to a wound bed by adding saline. But saline will eventually get absorbed by the body, and the body's going to see that as just natural water. So what we can add to wound areas is hydrogel. Hydrogel is a petroleum jelly product that will keep the area moist and effective and in an optimal healing environment while you're actually treating the wound, right? This can be used, I usually put a little bit of this over, even when I'm doing impregnated gauze, I'll put a little bit of this over the wound, any exposed bone or tendon, just to keep stuff from sticking to it. It'll help just a little bit more. This can also be used in the peri-wound area, but a lot of times in the peri-wound area, we're going to use more of a barrier cream. But this donates moisture to the area. There are all kinds of gels out there, right? This is silver-absorbed gel, so this is the same thing. This is just a hydrogel with silver in it. This can help promote antibacterial and antimicrobial technique, and it also can help promote some of the body's natural autolytic debridement. So the moister we get the wound, the more it helps promote that autolytic debridement, where the body itself tries to push off the slough and push off the eschar and get rid of the devitalized tissue, right? And here we have another wound dress. This is just a collagen hydrogel, right? So there's all kinds of them out there. There's also stoma adhesive. Stoma adhesive is used on the peri area around where you have patient has a colostomy or an ostomy bag. This will be used to fill in the cracks around the actual opening, the wound opening where the actual stoma bag is coming out, because a lot of times that area becomes cracked and dry. Well, if it's cracked and dry, well then the actual bag that goes over the outside doesn't seal very nicely. So this goes in, it can be used on the peri-wound area, and allows it to make a nice smooth seal over that stoma. So these are really kind of important for patients that have ostomies. And obviously we have things like TheraHoney, right? And we'll talk about the difference between autolytic and enzymatic debridement in a little bit, but these allow for debridement of wounds, right? Here's that barrier protectant I was talking about. Barrier protectants used typically on the outside of the wound bed. So autolytic versus enzymatic debridement, right? Autolytic means using the body's own natural chemicals to debride a wound, right? In doing that, we keep the wound moist. If we don't keep the wound moist, it will not autolytically debride the wound. It won't try to force off that devitalized tissue. It'll try to maintain it, because as the wound dries out, it's going to suck everything down back to it. So we've got to keep that wound area moist. TheraHoney can be used to promote that autolytic debridement, right? TheraHoney is just a natural occurring honey that's sterilized for wound care. It works really great on debriding tissue. Meta-honey may be another term you hear for it. It really helps with necrotic tissue. So that type of stuff, it doesn't necessarily always remove eschar, but you do usually with these, and even with Santil, you need to have some vitalized tissue there in order to help force off the devitalized tissue. So it's not like if you just put this on, it's going to just eat away at everything. You need healthy tissue underneath it in order to work. We don't have an example of Santil here, but Santil is a prescription anti-enzymatic debrider. It's actually an enzymatic debrider, not anti. And Santil goes in and softens. It's often used along necrotic tissue. It literally cleaves it along the collagen barrier, so it actually forces that tissue off, and it basically turns it to a mush that can be easily removed. Santil is prescription only, so we can't just use Santil on any patient. You have to have doctor's prescription in order to use it. That also means you have to get an order through the PT to use it on top of that. If we don't have any order in there to use anything like TheraHoney or using Santil, we have to consult with the PT first. The PT has to give us clearance on what we're going to use on the wound. Hydrogel, not so much. If we need to use hydrogel, that's just donating fluid to the area. You still want to advise PT maybe if you had to use hydrogel in the area, but you don't necessarily need to get a prescription for using hydrogel because it's just a petroleum jelly product. We start adding these where we're starting to get silver in it. Yes, we do have to get clearance from the PT to use it. Santil is specific to the patient because it is going to be a prescription. So that means if the patient has Santil order for them, that has to have a label on it that is labeled to the patient. You're going to get the labels from the chart, usually at the nurse's station. You're going to place that label on that, and it's going to go in the locked medicine cabinet of your wound care cart. It has to be locked up because it is a prescription. It doesn't matter if it's not, an opiate or anything like that. Because it is a prescription, it has to be locked up. So then we talk about like the wound care cleansers, right? So all the companies out there will sell you all kinds of fancy wound care cleansers. So we've got a couple samples here. I usually like to get them when I'm going to the different seminars and stuff like that. This is Skintegrity. These are TheraWorks cleanser. This is Santa Cleanse, right? I'm not saying these are totally bad, right? But most of these have some form of acid in them in order to help with debridement. I don't like using these on wounds because I don't like putting, like this one has citric acid in it. I don't like putting citric acid in a wound. Imagine you've got a paper cut and you open an orange. Well, that's citric acid. It doesn't feel so great, right? Now, most of the wound bed is going to be, have not functioning nerves, so it may not bother it all the way, but you get to those edges, it's going to burn. And it's not always comfortable for the patients, right? You can use these. If your clinic uses them, then, hey, if you're told to use this by the PT, use these by the PT. But traditionally, what I see most wound care therapists, and when I say wound care therapists, PT specifically using, is just natural saline, right? I like this one here just because it's got a little bit of force to it and it can spray. This is just your traditional little sodium chloride saline bottle. Most hospitals have these. Even just getting something as simple as a saline bag from storage, that'll work as well. But this just helps clean the wound out. We're going to see when we actually clean the wound how we use this to clean the wound, but I'm going to use this like anything else. You're going to use it to wipe out any excess gunk that's in the wound, and also help donate moisture to that wound. So that wound is nice and moist and prepared for dressing. I prefer, again, using just the simple saline, but again, if your clinic uses this, this is not necessarily bad. This one says that it's totally body safe, low pH, non-cytotoxic, right? But then you go down here and it's got a bunch of stuff, and this one's got colloidal silver in it, so it's got some antibacterial, but this one again has, here goes, citrus grandis, grapefruit juice extract. So I don't know that I want to put citric acid into a wound. But again, that's up to your clinic. If your clinic uses it, go ahead and use it. This is a broad spectrum hygiene treatment. What is this one? This is a barrier system hygiene treatment. The Skin Integrity, what does Skin Integrity have in it? It says, again, anytime it says loosen and removes protein and wound debris, that usually means it's got some form of an acid in it. Sorbitol acid, there it is. Lactic acid. So it's got at least two forms of acid in it. So you want to be careful when you're treating the wound area. So when you're getting this stuff from the supply cabinet, right? So most hospitals are going to have a supply cabinet on every floor, or supply closet on every floor. unless your clinic has a dedicated wound care cart. And you still may need to fill up that wound care cart from the supply closet, right? So just understand your hospital standard procedures. If you don't have a dedicated wound care cart, what you're probably going to have to do is go to the supply cabinet on the floor and get what you need. You want to make sure you know what you need before you leave that room, because every time you leave the patient's room and come back, you're going to have to wash your hands, foam in, foam out, all that jazz. Again, put new gloves on. You can't just foam in, oh, I forgot this, go out and get the stuff and start all over again. You want to make sure you have everything you need when you go into that patient's room. So most hospitals, like I said, will have a supply cabinet. In that supply cabinet, there's usually one of those little handheld scanners like you see at Walmart. And then there's going to be a wall of stickers with barcodes on them. You're going to pick the barcode of your patient. You're going to scan that barcode. And then you're going to go down the line and scan what you're taking out of that closet. All that stuff has to be accounted for. Anything that's not accounted for can be lost in waste, and we don't want to do that. That cuts down on our operating costs. We want to make sure that we are using what we need, right? If you don't use all of something, label it for a patient and use it later. But don't just grab everything, go in there and go, oh, well, I think I'm going to use this and this and this and this and that. Know what you need. That's why it's kind of important. It may be useful when you're writing your SOAP note to place what you used previously in the SOAP note so that you can get the same stuff the next time you go in. Once you have that all scanned in, then you're going to take all that and you're going to go to the patient's room. Understand, once you cross the threshold to that room, that's where you're at the point where if you go outside of that again, you've got to wash and scrub all over again. And that can be time consuming. And in wound care, we want to get through as many of them as possible in the day so we make sure that everyone's taken care of. Any day that we skip on wound care promotes an unhealthy environment in that wound. So we need to make sure that while we're taking care of these patients, we're also taking care of our supplies and taking care of ourselves, right? Standard precautions apply. We're going to use the clean technique most times when we do wound care, right? Clean technique means we're going to foam in, we're going to wash, we're going to wear gloves. A lot of times you may wear a mask if you're cleaning out the wound area or using something like a pulse lavage where fluid can fly back up at you. You don't necessarily have to wear a gown unless the patient's on contact precautions. It's up to you. If you know that the wound is going to get messy and you need to wear a gown, wear a gown. But inform the patient why they're wearing a gown. You're wearing a gown because that can get a little bit uncomfortable. If you're coming in, you're the only person wearing a gown, the patient wants to know why you're wearing a gown. So be upfront with your patient, right? When you go into the room, tell them you're there to do wound care and that's what you're here to take care of. Make sure that when you do the wound care, you time their pain medication around 20 to 30 minutes before you come in to do wound care. Ideally, 40 minutes would be perfect. You want them to be at that peak efficiency of their pain meds so that when you go in and start digging around in that wound, it doesn't hurt them as much. That leads to a more compliant patient with wound care. If we're constantly going in when they're non-medicated, they're going to become uncompliant, right? Which means they're going to start refusing treatment, and when they start refusing treatment, that area breaks down and that wound gets worse. If a wound gets worse in a hospital, oftentimes it is on the hospital to pay for that. So our job when we're doing wound care is to make sure that wound is constantly progressing or getting better, right? When patients come into the ER, come into the hospital itself, a lot of times they're going to be screened for wounds. They're going to be checked all over to make sure they don't have any pressure injuries, they don't have any cuts, scrapes, abrasions, anything like that, because that's got to be documented. And if it's documented, it can be treated. If it's not documented, then we have no way of showing if that wound occurred outside the hospital or inside the hospital. So we have to be aware of that. We have to make sure that we're protecting the hospital, protecting the patient, right? And we need to indicate if we see a new wound, we need to report it, right? First, obviously, would be a report to the nursing staff of that patient. Hey, John's got a new wound here. Make sure you report it. Make sure it's documented. Make sure you tell your PT. Because anytime we have a new wound development, that can be a progression in the patient's case, and we need to understand what's going on with those patients. That's it primarily for, the only other one I forgot about this one. This is Tender Wet. Tender Wet is actually a hydrogel impregnated gauze. You can use this obviously for too dry of a wound. So I totally forgot about the Tender Wet, but it's there. But that's it for the dressings themselves. Now what I'm going to do is I'm going to get set up and we're going to look at a patient that's already got a dressed wound. We're going to set up to take care of that wound, and then we're going to dress the wound. Okay, I'll see you in a bit. I'll see you in a bit, Mr. McKeever. That's fantastic. That was really creepy watching myself. So with that, did that help explain some of the different types of dressings and stuff like that? So the good news is that video is up that you can watch at any given time. That is a lot. Yeah. The main thing you need to take away from that, and the main things are, know your wound bed. Is it dry or is it moist? Is it too moist, right? Very rarely are the wound beds just right. Usually we're on one side or the other. We want to get them to just right. Excuse me, if it's too dry, we add hydrogel. If it's too moist, we use alginates. That's primarily the two golden rules that we have with wounds. If it's kind of just right, we just use standard kind of moistened gauze and we'll be happy with it. There are a ton of products out there. I mean, every time I go to one of these conferences, there's some new product that's better than this and better than that. And usually better than means expensive. So just because a company says it's better doesn't necessarily mean that it actually is better. Most of those products that we have there are the stuff that's in every single hospital. Some of the fancy stuff like the Silva absorbs and the Max absorbs and stuff like that are more specialty, but it is a lot of stuff. So if you're doing wound care, you kind of have to know what your hospital has. But again, most of wound care comes down to taking the old dressing off. Is the wound too moist? Then we take away moisture. If it's too dry, we add moisture. And then we redress the wound. There is a whole video up there after that on changing a wound dressing. That actually I put in the very first lecture day. There was actually a whole section on that I put up there that this video is up for you. Take and watch it. We went over the technique, but this at least lets you go through it. Are there any questions about today? I know it's a lot, it's heavy, but this is why we have this 6-week class, because we want to cram as much into your brain as possible and make you have a aneurysm for too much information. Any other questions? Anyone awake? No questions? Let's stop recording.